Assalamu alaikum. Welcome, our Malaysian student. I am so happy to be with you in this important lecture, and also I am so sad to miss your interaction and your presence and with us. Truly, I enjoyed learning with you and your previous batches in the previous years. Our lecture today is one of the most important subjects in toxicology is about pesticides. Pesticide is very important because it's a widespread health problem among developing and even developed countries. And your previous colleague in previous batches told me that the incidence of pesticide poisoning in Malaysia is so high. Okay, this is me, Dr. Khaled Saad, Professor of Clinical Toxicology, and this is my email. You can contact with me through this mail or WhatsApp through this mobile number. Okay, I always like this picture that represents Malaysia, and I know that it has special importance for you because this is an important tower in an important square in Malaysia. So it's a very nice picture, and I always I be happy when see this picture, and I know that you will be so happy to find this picture in the start of our lecture. Okay, let's agree to be smiley through the lecture. Please keep smiley because when you are smiley, you can get more information and you can learn more. Okay, and always keep interactive. Truly, Malaysian students are very interactive, and I enjoyed your interaction during our lectures, but unfortunately our condition today don't permit our presence together, but we will try to be interactive even through this video lecture. Okay, what this picture present? Yes, as you said, this picture present represent one who is spraying pesticide, and as you see the head of the sprayer in the form of copra. Why? Yes, to tell you that although we get benefit from pesticide, but pesticide can kill us and they can deal with us as what copra deals. So take care to avoid the hazards of different types of pesticides. This poster, as you see, to tell us that's pesticide free, because Western and developed countries has a phobia from pesticides, so they put this sticker in restaurant, in hotels, in coffee, to tell the audience that this site is free of pesticide because, as I told you, they has a phobia from pesticides. If you know the Prince Island is one of the famous areas in Istanbul. Even if you went to Istanbul, you will visit Princess Island. This area is free of pollution, free of pesticides. It's not allowed to use pesticides in this area. Also, it is not allowed to drive car or any types of motorcycles to avoid pollution or any type of pollution that may present in the air, in the water, and the food. So this sticker tell us how the Western and developed countries deal with pesticides. Okay, so what is the objective of our lecture today? Our objective is to 1. Define pesticides and different types. 2. Discuss hazards of pesticide. 3. And the most important is to evaluate cases of pesticidal poisoning and how to deal with them. And this is the most important objective because you will be graduated inshallah, and you will be a clinician. So it's important to know how to deal with different types of pesticide poisoning. This picture tells us the instance of different types of poisoning. As you see in this picture, that organophosphate, which is one of the important pesticides, have the highest percentage, more than 1/3 of cases of poisoning is due to organophosphate, which is a member of of pesticide. So pesticides represent a high ratio of cases of poisoning come to the emergence. Nowadays in Egypt, aluminum phosphide and zinc phosphide started to be frequent cases among emergency department and among different poison control centers. In Malaysia, the incidence of pesticide poisoning is mostly due to paraquat, which is a type of herbicide poison, and will be discussed during this lecture, inshallah. So, what is pesticides? Pesticides, as you know, consists of two terms, pest and side. Side means to kill, to eradicate, to get rid, okay? And pest means that a biological hazard, okay? To nominate thing that pest, it must be biological and must be hazard, carry hazard or toxicity. So, according to the definition of pesticides, pesticides may be in the form of insect, herb, and rodent. So we can classify pesticides into insecticides, which are directed to insects, either small or large insects. Herbicides who are directed to herbs, or rodenticides that are directed to rodents, which represent small animals like rats, mice, and these different types of rodents. Okay, this picture represents different types of insects and large insects, and this represented different types of herbs, and this represents rodents, different types of rodents. Okay, we can classify pesticides into natural and synthetic. Natural represent a large group today because developed countries are coming back to natural insecticide to avoid hazards of synthetic insecticide. We can classify synthetic insecticide into organic and inorganic. Then we can classify organic insecticides into cholinesterase inhibitors and organochlorine, then inorganic like arsenic and cyanide. And note that use of inorganic insecticide is limited, but the most used is organic insecticide, synthetic insecticide in the form of cholinesterase inhibitor or organochlorine. All those organochlorine has banned in many developed countries due to their persistence in the environment. So the most used organic insecticide are in the form of cholinesterase inhibitors. Cholinesterase inhibitors may be in the form of organophosphates or carbamates. If you enter to any market of pesticide market, you will see these different types of organophosphates present in the market in different names, different trade names, different concentrations, but mostly in the form of organophosphates. Okay, how can organophosphate poisoning occur? Most cases of organophosphate poisoning in the form of accidental poisoning. Because organophosphate is present in the form of powder and solvent, then the powder is put in the solvent, which is mostly in the form of petroleum distillate. Then after that, it's put in the container, then put in the sprayer like that, and after that, it's used for spraying insects. So during the process of reconstitution or putting in the container or putting in the sprayer or spraying, organophosphate poisoning can occur. In the process of spraying, must have protective measures like wearing a mask, like this picture, like noting the direction of wind to avoid exposure to organophosphate. If this precaution is not respected, the person will be exposed to organophosphate poison. And this is a picture to put in the farm using spraying to notify the person that to avoid exposure to organophosphate in this area in case of spraying in this farm. Small kids or children going to farm after spraying, as you see in this picture, can be exposed to organophosphate poisoning through eating of contaminated food. Also, animals can be exposed to organophosphate poisoning if they were present in the area of spraying of organophosphates. Okay, what will organophosphate will be after exposure? What will our body do with organophosphate? Organophosphate is absorbed by all roots because it is highly lipid soluble, so it's exposed. It is absorbed by all roots. Can be exposed through skin, can be exposed through inhalation, through conjunctiva. Any root of skin or mucous membrane can absorb organophosphate. But note that the most rapid route of exposure, so true, as you tell me, it is the through inhalation is the most rapid route. But the main route, that is the route that a very large portion, okay, so the most rapid is inhalation, but the main route is the skin. After absorption by skin, it will be absorbed and go to circulation, and those the upper arrow tell us that it go here to the brain and pass blood-brain barrier, inducing central manifestation. Also, it will go to the high lipid content because it has a lipophilic properties. Okay, and this is an important point in the kinetics of organophosphate. Okay, so what is the mechanism of toxicity of organophosphate? You will know that normally acetylcholine is an important neurotransmitter in the nervous system, and after liberation of acetylcholine, it will be cleaved by acetylcholinesterase enzyme into choline and acetate after doing its action. So acetylcholine will be liberated, induce its action, then cleaved by cholinesterase enzyme into choline and acetate. In this picture, you see that organophosphate come here to cholinesterase enzyme and inhibit cholinesterase enzyme. Okay, so cholinesterase enzyme in the form of yellow star that normally cleave acetylcholine in the form of these black squares, okay, will be inhibited by organophosphate. Please note that at the first, combination of organophosphate with cholinesterase is reversible. That means that it can leave it and this takes about 12 to 18 hours. After that, it will become irreversible. So, it will not leave cholinesterase enzyme. So this is an important point in the treatment, because during the period of reversible inhibition, we can give the patient what's called cholinesterase reactivator that can cleave the bond between cholinesterase enzyme and organophosphate. But after that, even the patient received cholinesterase reactivator, it has no function, because as I told you, after about 12 to 18 hours, the bond between organophosphate and the cholinesterase will be irreversible. Okay, so inhibition of cholinesterase enzyme will lead to excessive accumulation of acetylcholine at the neurotransmitter, different sites of neurotransmitter, leading to what's called cholinergic crisis or excessive accumulation of acetylcholine. Okay, to suspect or expect the manifestation of cholinergic crisis, we have to know the sites of acetylcholine in the nervous system. As shown in this table, the acetylcholine may be present in the central receptors or in the peripheral receptors. In the peripheral receptors, there is nicotinic receptors and muscarinic receptors. Muscarinic receptors are present in the postganglionic parasympathetic to heart, exocrine or smooth muscle, and to sympathetic to sweet gland, to sympathetic postganglionic to sweet gland. And the nicotinic receptors may be in the motor endoplate, suprarenal or adrenal medulla, sympathetic and parasympathetic ganglia of peripheral nervous system. Okay, so these sites are the sites of acetylcholine, and the manifestation that appear due to accumulation of acetylcholine in these sites. According to this table, we can classify the manifestation of excessive accumulation of acetylcholine into central manifestation due to presence of central receptors, muscarinic manifestation due to accumulation on muscarinic receptors, or nicotinic manifestation due to presence in the nicotinic receptor. The first manifestation to appear mostly are central, followed by muscarinic, and the nicotinic appears only in severe cases of poisoning. Okay, this picture represents the sites of acetylcholine, as you saw here, postganglionic parasympathetic and sympathetic to the sweet gland. Okay, and these are called muscarinic receptors, or here in the motor endoplate here, motor endoplate, or in the adrenal medulla, suprarenal medulla, or in the autonomic ganglia, and these sites are called nicotinic receptors. Okay, so the clinical presentation of acetylcholine is a mixture of central, nicotinic, and muscarinic. As I told you, the first manifestation to appear is the central manifestation in the form of confusion, aggression, irritability. After that, the muscarinic manifestation will appear. It present in the word dumbbell, diarrhea, urination, meiosis, bradycardia, bronchorrhea, lacrimation, emesis, salivation, and sweating, and the nicotinic effect. Nicotinic effect may be present in the motor endoplate, or in the due to suprarenal, or in the nicotinic, or in the autonomic ganglia. So the manifestation of nicotinic effect mainly in muscles, in the form of increased contractility in the start, and later on there will be paralysis of these muscles. Also take care that solvent of organophosphate, I told you that it's put in the solvent, it's mostly petroleum in the form of petroleum distillate. This solvent may induce hydrocarbonuritis. So these manifestations are due to organophosphate itself, but hydrocarbonuritis is due to the solvent of organophosphate. Okay. So what are the most cause of death in case of organophosphate? You know that Pharaoh died to do drowning. So what is the relation between Pharaoh and the patient or the person of organophosphate poisoning? You know that among the presentation of organophosphate poisoning is bronchospasm and bronchorrhea. This bronchospasm and bronchorrhea may lead the patient to die inside himself. It's called that is due to drowning, due to this presence of these secretions and the presence of the bronchospasm. We call it the patient will be drown inside himself because the secretion inside his bronchi and the bronchospasm act exactly as he is drowning. So that is the relation between the person of organophosphate poisoning and the Pharaoh, because he is died due to drowning in the river. And you know our Quran, وجاوزنا ببني إسرائيل البحر، سورة يونس، فاليوم ننجيك ببدنك لتكون لمن خلفك آية. فاليوم ننجيك ببدنك لتكون لمن خلفك آية. Okay. Also, paralysis of respiratory muscle due to nicotinic effect may play a role in respiratory failure. Also, inhibition of central respiratory center due to effect of organophosphate in the central nervous system also play a role, but the main role is the bronchospasm and bronchorrhea, and this is the main target in treatment of patient of organophosphate poisoning. There are other rare causes of death in organophosphate poisoning, like arrhythmia that may occur, like dehydration and electrolyte imbalance, like pancreatitis, and different cause, but the main cause is respiratory failure, and the main cause of respiratory failure is bronchospasm and bronchorrhea. Okay. We may need to do some investigation as cholinesterase level, arterial blood gases, amylase, ECG, radiology. Okay, and you have to differentiate it from carbamates and from meiosis. Meiosis, you know that there are some poisons or toxins that induce meiosis. I hear someone, if you tell me that that are different causes of meiosis, because it's an important point on toxicology. Also, gastroenteritis. Gastroenteritis can be confused between organophosphate, because here we has nausea, vomiting, and diarrhea, so it can be confused with gastroenteritis. Okay, so what is the treatment of cases of organophosphate poisoning? The first two is to keep airway, and keep breathing, and keep circulation, because these are EPC, and this is important in any case of poisoning or any case of emergency. We have to keep patent airway, to keep breathing. You know that airway, there are secretion, and these secretions can close airway, so keep patent airway, keep breathing, because I told you that respiratory muscles may be affected, so keep intact breathing, and we may need to do artificial respiration, or in severe cases a patient may be put in ventilator, and see and to keep circulation, avoid treat any type of arrhythmia, any type of shock, or any impact on the cardiovascular system. Also, we need to do decontamination. I told you that the main route of exposure is the skin, so we need to decontaminate the skin. We have to decontaminate the skin. And lastly, we have to use the antidotes, which is in the form of atropine or oxime, and we will discuss them now. Okay, these pictures show us decontamination in the farm. As you see here, after exposure to organophosphate, the patient put in the farm, and we get rid of his clothes. We get rid of his clothes, and after that we wash the skin with soap and water, and the caregiver must wear protective gloves to avoid exposure to organophosphate. Okay, so atropine is the physiological antidote. Atropine is the physiological antidote. It reverses muscarinic manifestation. It reverses muscarinic manifestation, and have in the dose of 1 to 2 milligram intravenous until dryness of bronchial secretion. So it reverses muscarinic manifestation and given until dryness of bronchial secretion. The patient, after we give him atropine, we observe for 5 minutes. If no improvement, we can double the dose. If it improved, we continue on the same dose. The target endpoint for atropine therapy is clear chest and auscultation, because this is the main target, and the heart rate more than 80, because this means that bradycardia has improved, and systolic blood pressure more 80, and dry axilla, sweating has been improved, and the pupil no longer pinpoint, improvement of meiosis. Okay, after the patient reached the target endpoint, we can withdraw atropine gradually to avoid atropine toxicity. If the patient signs of atropine toxicity appear in the patient, we can stop for 30 to 60 minutes, then reassess the patient, but take care to avoid atropine toxicity in cases of treatment of organophosphate poison. Okay, this picture in the war, organophosphate may be used in chemical war, so it may be present in the form of sarin gas. So this soldier exposed to organophosphate and signs of toxicity appeared, immediately he is treated with atropine to avoid the appearance of muscarinic manifestations. Okay. So oximes is a specific antidote that regenerate enzyme and improve nicotinic manifestation, but and given in dose 1 to 2 gram in meat millisaline over 30 minutes. Take care, as I told you, it must be given during the initial period of poisoning, not more than 18 hours, because after that the bond is reversed. You see here the effect of oxime. It cleaves the bond between organophosphate and cholinesterase enzyme, and also prevent the binding or inhibition or phosphorylation of free enzyme by organophosphate. So it has two important actions: close the bond and detoxify organophosphate in this type of poison. Okay, carbamates is a new type of of cholinesterase inhibitor. The difference between carbamates and organophosphate is, number one, it has reversible inhibition of cholinesterase enzyme, so we don't need oximes. Also, it's poor penetration of blood-brain barrier, so we have no central manifestations. And oximes are not indicated, as I told you, because the inhibition of cholinesterase is self-limited. And here, as I told you, in organophosphate we have central, nicotinic, and muscarinic. In case of carbamate, poor penetration of blood-brain barrier, so there is no there is no central manifestation, although because it's self-limited, no nicotinic manifestation, because nicotinic manifestation appear in severe case. So the case of carbamate poisoning is mainly muscarinic manifestation. This picture represents the action of choline, the action of oximes in the carbamate here and in organophosphate, it appears that it has an important role in organophosphate poisoning, but in case of carbamate poisoning, it has no role and must be avoided. This, I know this picture is an important picture for you in Malaysia. Thank you for your audience, and we will next okay, this is again my email, and this my another mobile for me. You can communicate through that or the other mobile phone, and thank you for your attendance.